I am okay.
All right, thank you.
I have a hard time talking and being able to be heard. Good afternoon. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority, and I'm joined here today by Dr. Ariel Smits, Medical Director for our Health Evidence Review Commission, and we expect Dr. Tom Jean to be joining us here shortly. Thanks for joining us. For those of you out there just before a notable holiday weekend as cases continue to rise here in Oregon, so we'll give a little attention to that topic. But let's take a look at our agenda for today. We're going to give you our usual situational update, highlighting some notable trends and some new types of graphs that help us to get a better glimpse into this current COVID pandemic here in Oregon. We're going to briefly talk about and highlight the statewide masking updates and talk about your role to help us get the message out. I'm going to share briefly some Remdesivir news, this antiviral medication and what's coming from the federal government. We're going to talk about briefly some testing guidance updates, and then we'll share some highlights from literature coming out on COVID and answer some of your questions. And we will get started here. So situational update here in Oregon. As of yesterday, we don't have today's cases out, although we know a lot of testing is happening, but as of yesterday, there are a total of 8,931 cases. And the majority of those are based off of positive COVID tests. You can see here, we got this, I think we confused the audience last time a little bit, so we wanted to clarify that sometimes the numbers don't match up because we do collect information on presumptive cases. So a small portion of our total cases are considered presumptive cases. Just a little bit more about that. These are people without a positive PCR test who have had COVID-like symptoms and a close contact with a confirmed case. Though not confirmed by a positive diagnostic test, these cases have a very high likelihood of having COVID-19 because of the nature of their symptoms and their known exposure. And we're always encouraging these cases to get tested. If that test becomes positive, they are recategorized as confirmed cases by testing. So those two numbers are somewhat dynamic over time. We'll stop highlighting that, but wanted to loop back as that had been a question a couple weeks ago. Unfortunately, we continue to see a steady rise in deaths in Oregon. We've had a total of 208 deaths as of yesterday. And as you can see now, well over 200,000 negative tests completed in the state. Also, a little bit of a situational update looking at our weekly information. We put out a weekly report. Hopefully you all have had a chance to take a look at that. In the week of June 22nd to 28th, we had a total of 28,359 COVID tests reported as completed. And we had a total of 1,402 new cases during that week, which was an 11% increase from the prior week. As you've noted, probably we've had a week-over-week increase in cases for approximately the last month now. We're also seeing a rise in our percent positive tests. Last week, they were reported again at a higher rate of 4.2%. You may recall that our nadir had reached about 1.6% positive tests back in mid-May, and those have been slowly rising. And I've given you a little screenshot of our epi curve at the bottom. And all of the increasing cases you can see here over that latter end of the curve. We are monitoring this closely and really believe that there's probably multiple factors contributing to the rise in cases. First, I'll just highlight, we knew that as we moved into reopening, we would see more cases. That was a well-known expectation. And that is why we've been really focused on, while we reopen, to consider continued focus on physical distancing, minimizing, large social contacts, wearing face masks, etc. So we did expect some of this rise. We do think certainly that some of this rise is related to increases in the COVID-19 transmission and incidence in our community. We also expect that some of the rise is due to increased testing. We've had really substantial increases in testing over these last 3 to 4 weeks. This was the first downturn, if you will, from the prior week. I think last week we had over 32 or 33,000 tests completed, but certainly substantially higher than we had been seeing earlier in our response. We've also shared with you that there's been some very large outbreaks, including, within various workplaces, ongoing focus on outbreaks on long-term care environments and beyond. And we've also seen a rise in sporadic cases, which we'll show a little bit more information in just a minute. So I'm going to pass the slides to talk a little bit more about some of the trends we're seeing that I was referring to. And Dr. Tom Jean has been able to join us now, Deputy Public Health Officer and Deputy State Epidemiologist. So thank you for joining us, Tom, and I'm going to pass it off to you.
Yeah, so this figure just highlights our EpiLink trends. An EpiLink, epidemiologic link, refers to how many cases have been linked to a household or a outbreak. And so the blue boxes are the outbreak, the gray is household, and cluster, again, is just our term for a cluster of cases in space and time that maybe haven't been yet linked to an outbreak. So you can see there was a really big increase in outbreaks in week 23, 24, and 25. And week 26, which is the most recent week, I believe ending last week, you see a drop off in cases just because we are still having case reports come in from that week. But it does look like there is a decline in outbreaks and maybe an increase in sporadic cases not linked to an outbreak. We had talked about this last time, I believe. This is showing cases by age group, and really the highlight is we are seeing more cases diagnosed in younger people in recent weeks compared to early in the pandemic, especially ages 10 through 40 or 50.
And just a couple of comments that I think we shared during the last Project Echo session, but want to make sure this audience has heard it. We continue to try to understand some of these changes in age distribution over time. A couple things that I think we've certainly noted as part of this trend is one, just the broader increase in testing. We're probably capturing more younger people where previously we were focused on more severe disease in our testing. We're seeing more workplace outbreaks where the employees might be more representative of a younger group of individuals, and certainly picking up more younger kids through some of these outbreaks through case contacts and testing of symptomatic contacts. So those household members are certainly at some of the highest risk for exposure and transmission, and likely seeing this uptick from those. Anything else you'd add, Dr. Jean?
Oh no, those are very good points. Thanks for highlighting those. And it looks like we've got a typo. The N is now over 8,000 cases total cumulatively.
Oh yeah, sorry. I did not fix the header. It's in the fine print. All right, moving on.
So this is one of our public health indicators, percentage of cases with follow-up within 24 hours. That's public health follow-up. So when a case report comes in, how soon is local public health able to initiate contact? We want to see that over 95%. That's our target established. You can see in recent days, maybe dipping a little bit below that with the increasing caseloads that we're seeing. And even with hiring new contact tracers and some people who can do case investigation, we want to make sure we can stick close to that 95%. So we're going to keep a close eye on this. This is really important because the sooner you can identify a case's contacts and get in contact with the contacts, the sooner we can implement quarantine and testing of those people, and the faster we can reduce disease transmission. So important metric for sure. This is the percentage of cases not traced to a known source. I believe Oregon may be the only state that is publishing this data. And we also think this is important because it shows how much is beneath the tip of the iceberg in terms of community spread versus spread from people that, from context or from cases that we already knew about. So we would like to see that below 30%. In coordination or in alignment with what we're seeing for our rising case counts in Oregon, we may be seeing an increase in this, although again, sometimes the most recent days data are going to be a little bit skewed because we don't have full information yet reported.
Great, and as you know, one of the things that we are particularly focused on as we watch rising case counts is our hospital capacity during any continued surge of patients. This is, again, data you've seen before, but wanted to share with you again this trend where we've seen continued increases in currently hospitalized patients across our hospitals statewide. Our hospitals are doing a lot of work on their surge planning, on their coordination with each other in preparation, and considering all the steps that are needed as we monitor this data. Here you can see that we are getting closer to the peak that we'd seen when we started collecting this data back in April, whereby we have nearly 120 hospitalized patients with COVID across our hospitals statewide. You can see the proportion of those that are requiring ICU care, as well as those requiring mechanical ventilation. Our hospitals are, as I speak to them regularly, still feeling that they have adequate capacity to meet these needs, but of course we're all continuing to stay close attention to this topic. All right, just a brief amount of information on our statewide masking policy. Really just suspect that you have all seen this now. This was a change since last week. Initially, there was a requirement for masking in a subset of counties in our state, and effective yesterday, this has now been made a statewide requirement by Governor Brown. We're not going to go into too many details about this today. We invite you to visit the guidance. We give you the link here that spells out a little bit more information about the requirement for indoor public space masking and kind of who's involved, what businesses, and what is the general public requirements. We just want to really take a minute here to extraordinarily emphasize this importance of masking up. I would say, I would invite my colleagues here to share their impressions. I think over time we are learning so much about COVID and our needed response throughout the last 3-4 months of this experience. So much is fast-paced, new literature coming out, and new understanding. And I think we all are taking more opportunity to consider and appreciate the increasing evidence to support the importance of masking in the public. And so we hope that you will take the opportunity to spread that across that information across your colleagues about this importance across your family, friends, communities. Our state has now provided some social media toolkits and other tools to help you spread the word. I provided some of that information here as a link where you can download some of these little visuals as I've exemplified here. There's a whole host of them available right now that you can add to your emails, send out to your friends, post on social media, get the word out that this is actually a really important part of this phase. We want to keep businesses open. We want to keep people getting the healthcare they need. We want to keep being able to move forward in so many ways, but masking is going to be one of those most important tools for all of us. I know that there's going to be further public education campaigns forthcoming, but this is the beginning, and we invite you to take a look at some of the tools we have available and help us to spread the word. Anything you guys would add to that?
I've got some literature coming up about masks.
Oh, great, yes.
Preview.
Answering your questions, we're going to bring you some of the literature we're seeing now on the effectiveness of these masks, so stay tuned for a few slides.
And I would just say, when we say masking, we're referring to face coverings and Generally, mask refers to medical masks, but for the public, it's cloth face coverings is the general recommendation.
So also in other news, we've shared some information with you before around remdesivir. If you recall, remdesivir is a direct-acting antiviral that inhibits viral RNA synthesis. It does not have an FDA indication that has been approved to date. It has had many years of study for Ebola, SARS-CoV-1, and now SARS-CoV-2. And the federal government gave emergency use or issued emergency use authorization for remdesivir use for COVID-19 back on May 1st, based on some of the early top-line study data that had been conducted that showed some benefit that they expect outweighs the potential risks of the drug. Specifically, some of the studies showed a faster time to recovery for those who were treated with remdesivir versus placebo. That was statistically significant. And so remdesivir, as you may recall, has been distributed as donated by Gilead in an agreement with the federal government since middle of May. OHA, our state agency, has been receiving those shipments and distributing it out to hospitals upon request or for pre-positioning for use for patients who fit the inclusion criteria. Just earlier this week, however, we heard a new announcement. This was news to all of us. While we had just received our last donated shipment of remdesivir, the federal government announced that they have struck an agreement with Gilead, the manufacturer, to secure an additional over 500,000 treatment courses of remdesivir for the use in hospitals across the states through September. We have a lot more details forthcoming. Literally about all I know is on this slide that we're providing with you today. And I know our hospitals are anxious to learn more. We understand these quote unquote purchase drugs will now be made available as early as the second week of July. And we know that the federal government are working to provide FAQs and help us better understand what the cost of these drugs will be, what the mechanisms for payment might be, including insurance coverage, etc. If you want to learn a little bit more about this news, you can see the guidance here. There's lots of information online about what emergency use authorization includes for everything we've been talking about, from testing to treatments and beyond. So an update with more information forthcoming. All right, we're going to have Dr. Jean talk a little bit about our recently updated testing guidance that was just posted, I believe, yesterday.
Yeah, it was posted on Tuesday evening, I think. So this is, I guess it's not a minor update, but there were not major changes in the recommendations for testing. We recommend that anybody with symptoms consistent with COVID-19 be tested, and there is a list of groups that can be prioritized. Although currently we're not having significant testing shortages that would indicate that not everybody with symptoms could be tested. We do not recommend antibody testing. And we have a whole explanation of why in the guidance. I think it's on the last page, but it basically boils down to antibody testing is not good for diagnosis because it's likely not to be positive in somebody during their acute phase of illness. And we also really still don't know the extent of protection from antibodies for SARS-CoV-2. So again, our recommendations for testing of people without symptoms is on the second bullet point there, and we recommend these groups in particular, especially people who are close contacts of confirmed or presumptive cases, people who are exposed to COVID-19 in a congregate setting like a long-term care facility outbreak, for example, migrant and seasonal farm workers upon arrival to Oregon, and then people of color, people who have a disability, or people whose first language is not English. One of the big things we changed was we added a table here with suggested ways to message to patients what their test results mean. And so we have the two parts. The first part is for people who have symptoms, and we break it down by viral test and antibody tests. And again, we don't recommend antibody tests, but we recognize that they are happening, they're being done. And so I think rather than read through all this, I just wanted to highlight that this talks about what the results mean and what we recommend. For example, you should be isolating if you have a positive viral test, and what you can say to somebody if they have positive or negative antibody test results, and also highlighting the risk of a false negative from a PCR test. Great, and then some considerations that we wanted to highlight here regarding testing. So first of all, a negative test on an asymptomatic person does not mean that a person is not contagious, and that's because the risk of false negatives. Even for symptomatic people, about 30% of people who are actually infected will test negative by PCR on an NP swab. Even higher percentages tested by a nasal swab or with an antigen test will test falsely negative due to lower sensitivity. So that's for symptomatic people, but for asymptomatic people, we just don't have a lot of good data, but it's really likely and thought that false negatives would be more common because you're asymptomatic, you probably have a lower viral load, although we don't know that in every case. So it's really a concern in asymptomatic people that, you know, if somebody gets a test, they test negative, that there's going to be some degree of false reassurance there that they're not infected. And conversely, a positive test in somebody without symptoms does not mean that that person is contagious. We have well documented evidence now from around the globe that people can be PCR positive for many weeks long after they have ceased to be contagious. And that's because PCR detects certain sequences in the virus, but it doesn't necessarily mean that there is viable virus being detected. So in some cases, 60 days or more after symptom onset, somebody can be PCR positive, even though cultural virus is not found often. We've not seen evidence that cultural virus is found beyond 10 days after symptom onset. False positives are also possible, especially when we have a low community prevalence of disease, as we still expect is the case in Oregon. And that is even the case with a highly specific test such as PCR. Patients and providers should be aware that insurance may not cover testing for asymptomatic individuals. So that's one thing that should go into discussion when you're deciding whether or not to test. And then we wanted to highlight that patients may choose not to get tested due to potential consequences that they may experience from positive test. For example, lost wages or losing their job, being stigmatized by their community. And then for people in custody, they may end up being required to isolate or go into solitary confinement, and so those are all considerations for patients when they decide whether or not to get tested.
We are monitoring your comments in the text box, so I'm just going to call out one or two things, and we will certainly, some of these will be already captured in our presentation, and we'll come back to them time allowing at the end. But one thing one of you have offered is to really help us to re-emphasize one more time that antibody testing has extremely limited use, and we do not recommend it broadly. I think also among that point, we should highlight again, and I think we've done this before, that currently, for example, Medicaid in Oregon has limited coverage of antibody, really focused on those children who might be considered as having multi-system inflammatory syndrome condition. And I highly anticipate that the coverage is limited or spotty for commercial insurance. So it's not only a financial concern for your patients, but also has very limited use. And you have to be really careful on messaging about the implications of the test results, as we've highlighted in our new updated testing strategy, that again, what the result is has very limited, has to be really understood that it has limited application to what that person should consider in terms of their risk of exposure or certainly any protection. So yes, we're re-emphasizing that. Thank you for calling that out. I also saw a question here about what's being done to help migrant workers get tested upon arrival. I will say that there's a huge part of our state's response working on this particular topic, particularly supporting seasonal migrant farm workers, working with employers. And there's been a lot of testing done and testing set up to support incoming migrant and seasonal farm workers. I, of course, always anticipate we have more work to do, but that has been quite a focused effort, in addition to consider wraparound services needed, particularly around conditions of housing and other financial supports needed if unable to work. So a lot of effort happening underway on that topic. So thank you for calling out those questions. We'll keep coming back to this, to your questions as we move forward. All right, I am going to pass this over to Dr. Schmitz here to provide these literature updates as I actually am stepping away for another important meeting. I'm going to have our team here be monitoring the questions and moving these slides forward in my absence. So thank you for your brief pause here while we do a little exchange in positioning. And thanks to my colleagues here who are going to close out today's session with some really important information for you all.
Thanks, Dana. So I apologize ahead of time if I drive this slide wrong, but I will do my best. All right, so the first paper that I wanted to highlight actually is one back. This week in the Lancet, Chu and et al. Published a systematic review and meta-analysis of masks and face shields on transmission of COVID-like viruses. And it's not COVID-10, it's COVID-19. Another typo, sorry about that. So they pulled together a variety of studies and tried to kind of massage them together. So these would either be prevention of SARS, MERS, or COVID-19. They were either in healthcare or community settings. It was kind of a big mishmash of what they were looking at. One of the things they looked at was face masks versus no mask, and face mask could be anything. It could be an N95, it could be a cloth face mask, it could be any type of covering versus no covering. And looking at almost 13,000 people, they found a pretty significant reduction in viral transmission. So your chance of transmission of the virus was about 17% if you didn't have a mask versus 3% if you did. So if you have patients who are concerned that face masks aren't very effective, this is one good piece of information that you can share, that masking is a really powerful tool. Then they looked at face shields and eye protection. It was a little difficult to tell from the article, but my read of the article is this is in addition to face masks. They found 13 studies looking at this, and people who had no face shield had about a 16% transmission of virus versus about 5% for people with a face shield. Again, this may or may not have been in addition to masking. And then just a little bit more on face shields. There was a JAMA editorial. I just highlight this. It's an editorial, but they've brought together some really good resources and information. They talk about the Infectious Disease Society of America recommending face shields as one method. Face shields there was an OHA study from 2014 that they're highlighting here. It does limit viral exposure a considerable amount if you're coughed on directly. This protection does wane the longer you are with a coughing person. They did highlight that no studies have actually specifically looked at face shields as source control and without a mask, and they didn't think there would probably be any randomized controlled trials of this. But they did kind of conclude that face shields could be one portion of a strategy. And the reason I pulled this article in is that we had a bunch of questions about what about face shields if you can't wear a mask. So it sounds like they have some benefit. I pulled this article because we had some continued questions about ACEs and ARBs. Because COVID-19 may or may not have some connection to the ACE receptor, there's been a lot of concern about whether or not patients should be continued on their ACEs and ARBs. So this was a study that just came out in the New England Journal based on a group of patients in Italy. And they found basically no correlation to either severity of disease or patients overall getting the disease or fatality of the disease if you were on an ACE or an ARB. So this is reiterating all the literature that we have brought to you in the past. Please don't change your patient's ACE or ARB therapy based on COVID concerns. And then one other article that came out yesterday in the New England Journal about this multisystem inflammatory disease, just additional information. This is extremely rare. So they found, actually they found a little bit over 200 patients, but they removed ones that had previously been published in a New York case series. So they ended up with 186 patients. They're usually young, predominantly male. Mostly healthy, and the vast majority were positive. This is the one case where antibody testing can be helpful because most of these cases happen considerable time after the presumed infection. These kids are pretty sick. Most of them needed to be in intensive care, and quite a few needed vasoactive support, and about 2% died, although they did note that several were still in the hospital at the time of this publication. One of the really interesting pieces of information in this article I thought was that biomarkers for inflammation were sky high in these kids, D-dimers of 4,000 or more. So definitely something going on with inflammatories, something or other. And they did find that most of these kids had immunomodulating therapy. There was no ability for them to comment on whether this was helpful or not because this was just a descriptive case series. So going on to try to answer some of your clinical care questions. So this kind of reflects back to why I was pulling some articles on face shields and face masks. There's quite concern that face shields might not be a good alternative to face masks. The CDC on their website has kind of an interesting comment. They don't know if it's beneficial. They don't recommend face shields as a substitute for cloth face coverings, but if you cannot wear a cloth face covering, then you can consider a face shield, and in that case, it should extend below the chin and around the sides of your face. I wanted to point back to the Chu article in the Lancet that did find some protective effect of face shields, but not as high as face masks. That's probably mostly in medical settings. And again, for healthcare providers, face shields really should only be used in addition to medical grade masks. But in the community, if a patient cannot tolerate a face mask, consider a face shield. And then a lot of questions about contraindications to face coverings. It sounds like a lot of you all are having patients contacting you wanting medical notes to say that they cannot wear a cloth face covering for a medical condition. It's just some pieces of information that you can share with your patients. There have been studies showing no change in oxygen level or CO2 levels in patients with sort of the surgical type face coverings. So patients who have concerns that this will cause CO2 retention, there's no proof of that. Currently, OHA recommends face coverings for all persons. If you're under 12, they do want you to be closely supervised, and kids under 2 should not wear face masks, and nor should children who are sleeping. But if you have significant disability that makes it difficult for you to take a mask off, or making mask wearing unsafe, or significant underlying illness, those would be the cases. And that's up to your clinical discretion whether the patient asking for the medical note has a significant disability or severe underlying illness that, in your opinion, should preclude mask wearing. If someone says that they're having a difficult time wearing a mask, talk to them about different materials, which can have a significant impact on the ability to wear the mask or possibly wearing a face shield. The other thing to counsel patients about is if they feel that a medical note then gives them an ADA pass on going into stores. The ADA does not require that a store or a business or any other place allow you in without a face mask. It just requires reasonable accommodation. So for example, they could allow you to do curbside pickup, etc. So having this medical note does not mean that you can go shopping without a face mask and the store has to let you in. And then in terms of patients coming into your office or coming in to see you, there's various health system and clinic policies, and look at that first. And if you don't have one, you want to come up with a clinical policy. So hopefully that was helpful. The next question that we got was whether what kind of evidence do we have that you have immunity? And if you have previously had COVID, do you need to wear a face mask? We don't know. We don't know about what type of immunity you get. There are some studies showing that you do have short-term antibodies after infection. We don't know how long those antibodies last, and we don't know if those antibodies will protect you from future infection. So again, we just don't know. And if you have previously had COVID, you should still wear a face mask, because even if you have a known previous COVID, we do not know if you might be able to get it again. Next question. Actually, Dr. Jean, do you want to take this one? This is your area expertise.
Yeah, so there's a question about how long after exposure would it be best to test? And I would direct you to this review. It came out in mid-May. It was by some Johns Hopkins researchers, and they looked at 7 studies, 5 of which were peer-reviewed articles. And they looked at over 1,000 respiratory samples total in those studies using RT-PCR. And the findings were basically that sensitivity appears to peak on day 8 after exposure. And because median symptom onset is about day 5, that's day 3 after symptom onset. And it was interesting because on day 1 or 2 after exposure, there's essentially 0% sensitivity. On the day prior to symptom onset, it was, I think, below 20% sensitivity. And then it quickly rose after symptom onset, again, to 80% sensitivity on day 3 after onset, and gradually declined from there. So it does appear that it's really a couple days, 3 days after onset that it's going to be best. The day of symptom onset, though, I would still say it's high enough. I forget the exact percentage, but it's high enough that if you have a patient in your office who has just had symptoms that day, it's still worth testing. If a patient has a negative test and there's still strong clinical suspicion for COVID-19, then retesting is certainly reasonable, assuming you have adequate testing resources. And then in general, test results are most reliable in symptomatic patients. So when we're talking about asymptomatic testing, again, there are concerns about greater concerns for false negatives.
Oh, and so the next question, is there any talk of testing asymptomatic healthcare workers? We don't recommend testing asymptomatic anyone who's asymptomatic unless they have been exposed. So a healthcare worker who works, for example, in a skilled nursing facility with known COVID-19 would be a good candidate for testing. But if there's no known exposure and no known other risk, it's probably not a worthwhile screening to do. And then the last set of questions came in about ventilation and air conditioners, etc. This is really interesting. There have been some fascinating studies, mostly coming out of Asia, looking at like air conditioners and how the flow of air across a room. There's contacts that were sort of in that airflow. So definitely some interest in how air flows and how that may or may not put someone at increased risk. So the European Center for Disease Prevention and Control has come out with some guidelines. They don't think that an HVAC system, so this would be your typical building that does air conditioning and heating through a centralized system. The risk is very low in that type of system that there would be viral spread. But air conditioning units, like a window unit or a localized unit, may may kind of push out droplets over indoor spaces. And so you need to kind of be aware of fans or air conditioning units. They do recommend that you need to maintain your HVAC system, and there are filters that can filter out particles. So their actual recommendations are to maintain the heating and ventilation and air conditioning, make sure it's really up to date, make sure you're cleaning and changing filters as often as recommended by the manufacturer. If you have a fan or an air conditioner or other thing, you want it to direct it away from individuals so that you don't possibly have transmission of particles, and to avoid the use of air recirculation as much as possible. So this would be like a person in a car with someone else, for example. If you're having air recirculation, they're at higher risk if there's a source person in that vehicle or other things. So hopefully that answered some of your questions. And then I want to look at some of the studies that have been, some of the questions that you've been coming in. And I just turned off the question. I have a blank screen. I have apparently been locked out. Control Alt Delete. Well, I really apologize.
Is that,
Oh,
can we get back in maybe? All right, we'll work on it. Stand by. Okay.
all right. Let's see what kinds of questions. Recommendations about fans. Basically, just what I was saying, try to have fans not pushing air toward people. If, for example, you're at a grocery store and you have a checker who's always there, have the fan perhaps going from the checker outwards or something like that.
Well, I think I would just add that fans would be a great option to bring fresh air in. Not so great to be blowing air from one person or group of people to another.
Will a face shield meet the mandate for face covering in Oregon? Currently, the governor's mandate would be covered by a face cover. A face shield would be a type of face covering. This can be anything. It can be a bandana. It can be a t-shirt that you've cut up. It can be a face shield. Anything that would slow down the spread of droplets is fine. Again, a face shield alone is probably not adequate in a medical setting. What is the relative transmission risk outside if you have an unmasked person? I don't know if we know the actual risk. We do know that outside is safer than inside. I would recommend, and I think Dr. Jean would probably recommend, that if you come within 6 feet of somebody outside for more than a second or two as you run past them, it's probably not a bad idea to put a mask on. If you are out alone running and you are maybe just in very seconds contact with somebody, it's probably okay not to have a mask.
Yeah, and I don't have a citation for this, but I saw one study that I believe had estimated that the risk of transmission overall, the risk of transmission outdoors versus indoors was something like 19 times lower outdoors. And that's just a general estimate, I think. Obviously, if you're in close contact with somebody outdoors, it's still a significant risk, but outdoors is much lower risk than indoors in general.
Yeah, and I've seen that reflected. There's been quite a few studies now on the protests that have been going on and people outdoors shouting and being close to one another. It hasn't been a real big source of outbreaks, although I think there have been a few reported.
Right.
Another masking question: patients who have panic attacks induced by masks. If I write a note, does it mean their job has to let them work without a mask? That would be entirely up to the employer. First of all, the ADA only includes those with a disability. A panic induced by a mask probably doesn't qualify as a disability. The employer would have to think about whether they want to give them accommodation, and then they would need some type of accommodation. Maybe they could work remotely. They could be changed to a job where they are not required to wear a mask because they're not public facing. Really, it's up to the employer. You can't tell a patient that they have carte blanche if you write them a note. We had a note from Dr. Valerie King about a systematic review just done at OHSU on ACEs and ARBs. Yes, Dr. King, thank you for the reference. And they did a wonderful job with that, and it also showed that it doesn't, that article is also a good source of reassurance about ACEs and ARBs. Question about, well, case numbers and hospitalization numbers are increasing here, and so case numbers are going up and hospitalization numbers are going up, but mortality has fallen. What are your hypotheses on that? Is it a time lag, a younger population, other cause?
Yeah, certainly time lag is, the death is a lagging indicator, even more so than hospitalizations. We are seeing a significant change in demographics with a lot younger people who are younger, fewer comorbidities likely are being diagnosed more. So that's one reason. But I think time will tell. We'll see how much our death rate increases with these increasing cases recently.
How do we know that the long-term PCR positive person is no longer contagious after 10 days? What studies do you base that on?
So there were several studies, I believe 3 separate studies that CDC had referenced a while back, and I think that it's getting to be time that we would like to do a current evidence review of this again. But 3 studies that showed no viral transmission, no culturable virus after, I believe, 9 days after symptom onset. So that was what the recommendation, that was where the 10-day kind of estimate came from. I don't think that alone is enough going forward. I think we do need to look for more evidence that would confirm that there is not viable virus in that longer period. And there certainly could be people, perhaps people with weakened immune systems who have a longer period before they resolve the infection. But we do know for a fact that PCR positivity does not mean that there is viable virus, and that PCR can be persistently positive for many weeks, even in people who don't have it. And there's very limited evidence of transmission, when you get to be a couple months out from symptom onset. I haven't seen any hard evidence that there's actual transmission happening or documented.
Another good question. Guidelines around retesting asymptomatic people. If you are testing an asymptomatic person, what interval should you retest them?
Yeah, good question. It's a tough call because a lot of people are interested in screening and employers, and there's lots of settings where people are wanting to do asymptomatic testing. In the absence of a clear exposure, it may not be the best idea to do routine screening. And part of the reason is we don't know what the right interval would be, and we don't know how high the risk of false negatives is, but it seems considerable. So I think the point to emphasize is that when you get a PCR negative test, that is merely a point in time. It doesn't guarantee that and first of all, it could be a false negative, and it doesn't guarantee that you won't be exposed the day after your test, for example. The recommendation for serial testing has to take that into consideration, that it's really a snapshot in time. So we don't have any current guidelines about serial testing or screening for asymptomatic people.
Another asymptomatic testing question. Is the Oregon Health Plan covering PCR testing for asymptomatic clients? And if so, under what circumstances? So the Oregon Health Plan is unable to determine based on billing data whether a patient is asymptomatic or not. Currently, OHP is covering all testing that is ordered by a clinician. We're relying on clinician judgment for what's appropriate. Where can we find more information on helping migrant workers? I don't have that information. I believe it's on our website. We can try to get more information for next week's Project Echo if that's of a lot of interest to you all. Question about contact tracing. Is the metric for contacting contacts within 24 hours, is that the first contact, or is that complete contact tracing? In other words, the whole network?
Yeah, good question. So I need to clarify that metric is actually not contact tracing. That metric is for case investigation. And so just to be totally clear, case investigation is a little bit different. It's a more detailed investigation. So when we get a positive lab report or a report from a provider, public health does a case investigation, and that that metric within 24 hours is just initiating contact. So they may not have been able to complete the interview and the full investigation within that 24 hours, but we want to make sure that they're at least able to initiate contact and try to start the process. Beyond that, once the interview is completed, that's where contacts are identified, and then contact tracing happens, contacting those contacts happens separately by the contact tracers. So they're a little bit different. The initial case investigation and response to report, contacts identified, and then those people are contacted and quarantined.
Another contact tracing question. What % of the increase in cases in Oregon do we think are based on contact tracing versus actually increase in cases?
I don't think we have a number for that right now. We are recommending that contacts get tested, but the most important thing for a contact who doesn't have symptoms is that they are quarantining, doing a self-quarantine for 14 days in case they are asymptomatic, in case they are actually infected, to prevent transmission. We do have that metric on the cases that are tied to a known source, and so if that is kept high, above 70%, that's our target, and that means that new cases may be linked, or are linked. Majority of new cases are linked to a previous case, but yeah, I don't think I have a specific number.
So kind of a follow-up to that, then is OHA doing any metrics on the extended contact tracing? I'm assuming they're probably wondering if we have like a time frame that we want that done by.
Extended contact tracing.
I would assume that'd be out of OHA's control. That's the local public health department. We measure whether the first person's been contacted, but whether their entire network, and it would also really vary by the size of their network and types of, if they work in a grocery store setting versus they're in a nursing home. I mean, there's huge variables there. I don't think that could be a really useful metric.
Right. I mean, in general, local public health is attempting to get all the contacts elicited from the interview, and once they get those names, if they have contact information, they will follow up as soon as they can. But we don't have specific metrics on it.
I'm pretty sure this is a question that we'll have to summarize later. This is a pretty complicated one. Any studies or calculations about cumulative sensitivity, specificity, positive predictive value, and negative predictive value for screening disease and disease surveillance during the course of the diagnosis? There's a lot in there.
Yeah.
I think I would refer to the study that you had brought up about when the tests were positive and the sensitivity. If you want to just give that citation again, I think that's a good source.
Yeah, that was the link to that was on slide. We can bring it up on the screen again. Slide.
So I have it on the screen right now. It's the ACP journal, the first of the two there. That's probably one of the better studies to look at sensitivity and specificity and kind of how it changes over the course of someone's infection.
And if you're interested in the positive predictive value and likelihood ratios and things like that, I did cover that in our previous provider call. I guess that was 2 weeks ago. So if you look at the slides from that, I had a link to a website. I think it was the Choosing Wisely website that has a really nice calculator where you can put in the pretest probability, you can put in the sensitivity and specificity of a test, and get an estimate of predictive values and false positives, false negatives. It's really a helpful display.
Another masking question. Do all personnel who work in a medical clinic need to wear medical grade masks, even if they work in a closed room and not interacting with a patient? I think the current governor's recommendation is that all people wear some type of mask while indoors. Definitely, if you're interacting with patients, you want medical grade equipment. I think if you are not patient-facing and you're in a medical clinic, you need to just consult with your clinic or health system about what they would consider to be acceptable.
That would be the most important thing. That's probably going to be the more restrictive requirement. The governor's new order is for people in indoor public places. They must wear a face covering. But if you're in an indoor place that doesn't have any public, it's not open to the public, it's not absolutely required.
Another question about wanting more information about agricultural workers. We've noted that, and we'll forward that to the Project Echo one for next week. That's of interest to you all. Testing asymptomatic family members. I think this would kind of fall into if they are contacts of a positive case, yes, they should be tested. If they are simply a family member of somebody who, because of their job, is more likely to be in contact, our recommendation again would be to not screen them because they're asymptomatic, unless they're persons of color or other groups that we think might have some health inequities that we want to address. I think that's pretty much. Someone asked about whether this platform can show questions from others. We're just really happy we can see your questions. I really apologize that you can't see the questions from others. That might be something that we could look at in the future. I know the Project Echo, that's been a really, really positive piece of the Project Echo, their presentations, is that people can kind of communicate amongst each other and share best practices. So that's something that we hope to hopefully have in the future. That looks more or less it, except for I'm sorry we can't answer the questions about the migrant workers, and again that will be
yeah, I guess I would just regarding that, I would say that we do have weekly partner calls, including calls in Spanish, where we address we hear a lot of concerns and questions and address those with some of our Spanish-speaking senior health advisors. We have gone out to several of the agricultural and food processing plant outbreaks, and we have helped conduct testing and provide support in those settings. At this point, I'm not sure that we are able to provide testing for all, from public health for all farm workers as they arrive. That is our recommendation. We do recognize there are some real concerns about employers who may not be excited to test their workers because they have a conflict of interest in terms of wanting to have workers working and not quarantined or isolated. So there are some real concerns there, and then of course, even if a farm worker wanted to get tested, they may have concerns about losing their job if they test positive. So it's really a complex issue, and we're continuing to work with those communities to try to make sure that their health is protected and the public health is protected through testing, while also respecting individual rights and livelihoods that they depend on. So we'll try to provide an update on that at our next call.
One last question, kind of going back to your comments about day 8 being the highest sensitivity. Basically, should we wait and test people on day 8 after exposure or sooner?
I would. Oh, yeah. I sort of addressed this. I would not wait until day 3 after symptom onset or day 8 after exposure. If somebody has symptoms, and especially if they have a high likelihood of previous exposure, their symptoms are consistent with COVID-19, I would not wait. But again, if you have a high clinical suspicion and you get a negative test, you might consider retesting, and that would definitely increase your sensitivity.
This is our final question. In the face of limited resources for contact tracing, should counties prioritize contacts who are at increased risk of disease, such as those contacts with maybe chronic illnesses or young children?
Yeah, I think that would be reasonable especially if there are limited testing resources, which may be the case. We're seeing some potential supply chain issues nationwide, so we're keeping a close eye on that. I think that's all the time we have for today.
Sorry, someone really wants their question answered. Please advise providers to not release from isolation or quarantine. Leave this to the public health department. There's lots of providers telling cases they can go back to work prior to what the public health department says.
Oh, absolutely, yes. Public health is the one who makes determinations for isolation and quarantine for the people, yes.
And then we did get a couple of questions. I just want to let you know about questions about differences between Europe and the United States. That again might be something that we could look at for either a future one of these calls or for Project Echo. All right, that's all the time we have for today.
Thank you, everybody. Thanks for your attention and your
I
questions.
just wanted to let you know we're going to continue to do these OHA presentations on the first and third Thursdays at noon to 1. And then the Project Echoes presentations are going to be on the second and fourth Thursdays from noon to 1:15. And again, this is the slide that you're seeing now has all of those resources. So thank you all for participating.